Valvular heart disease. There are a spectrum of lesions or defects affecting the four valves of the heart, but namely, we'll talk about the aortic and mitral valve diseases, including stenosis and regurgitation for each of them. Before that, just to remind you how the valves are located in relation to each other. First, aortic insufficiency, which results from disease of the valve leaflet or the aortic root. Etiology. The commonest cause of aortic insufficiency is rheumatic fever, but there might be some other causes regarded as causative factor for the aortic insufficiency, like in Marfan syndrome, there will be a new low aortic ectasia or bicuspid valve, myxomatous degeneration of the leaflets, infective endocarditis, trauma, ascending aortic dissection. Pathophysiology of aortic insufficiency. There will be drop down in the diastolic blood pressure and by turn decreased blood flow to the coronaries, but work effort of the heart will be increased. Aortic stenosis pressure overload, aortic regurgitation volume overload. This is just to remind you. Clinical features. This might be asymptomatic, but when symptomatic, there will be dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, angina, symptoms of congestive heart failure if not treated. Management of aortic regurgitation. Most of them require surgical correction if medical treatment fails. Timing of surgery difficult in asymptomatic or mild symptomatic, but surgery should be done before heart failure occur. Catheterization needed. Sometimes CT angiography for the ascending aorta or the arch is necessary. Indications of surgery. When it is severely or acutely symptomatic, or it might be associated with other diseases like coronary, valve, other valve, aorta. When there will be significant left ventricular hypertrophy or significant left ventricular dilatation, meaning that in diastolic volume more than 55 millimeter. When there will be decrease in the ejection fraction below 50. Surgical options. Repair of the aortic valve is favorable, but if it is not possible, replacement of the valve only or with a conduit in case of aortic dilatation. Transaortic valve implantation or TAVI is newly practiced and it is good for some conditions. Now, aortic stenosis. Etiology of aortic stenosis. The most commonest one is calcific degenerative, or there might be congenital, like in case of bicuspid aortic leaflets. Others include rheumatic, obstructive infective vegetation, hyperlipoproteinemia, Paget disease of the bones, systemic lupus erythematosus, radiation of the chest. Presentation of aortic stenosis. It might be asymptomatic also, but when it is symptomatic, the patient might complain of chest pain, shortness of breath, or syncopal episode. Physical examination. First of all, the pulse, which is characteristic for the aortic stenosis, is parvus et tardus character of the pulse, which means slow rising pulse, and the murmur in systole. The second half sound is diminished or absent in severe aortic stenosis. Diagnosis and tests. Electrocardiography, ECG, reveals left ventricular hypertrophy. Chest radiography may be normal, or there might be enlarged heart, especially left ventricle. Echocardiography is helpful in the assessment of ascending aorta and the severity of the aortic valve stenosis. And finally, dopamine echocardiography, which is necessary to determine the severity of the aortic valve lesion. Choices of management. The important thing is to remember not to use vasodilators in cases of aortic stenosis. There might be options for treatment like balloon valvoplasty, surgery, repair, or replacement. There are special indications for ballooning. First, bridge to surgery in hemodynamically unstable patients. Second, palliation for seriously ill patient. Third is requiring urgent intervention. Indications of surgery. First, when it is symptomatic, whether acute or severe, or there might be hypotensive response to exercise. Second, when other surgery is needed, like coronary artery grafting, CABG. When there is structural valvular damages, whether symptomatic or not. Structural valve damages include left ventricular hypertrophy, ejection fraction drop down below 50%, and pressure gradient more than 50 millimeter mercury. Complications of aortic stenosis, congestive heart failure, sudden cardiac death, atrial arrhythmias, infective endocarditis, systemic calcium embolization, and prosthetic valve related complications. Mitral regurgitation. Mitral regurgitation is the backflow direction of blood from the left ventricle to the left atrium during systole. Etiology of mitral regurgitation. There are many. Coming from commonest to least include myxomatous degeneration, mitral annular calcification, rheumatic heart disease, congenital malformations, ruptured papillary muscle, ruptured chordae tendineae, Marfan syndrome, Ehlers-Danlos syndrome, others. Or it might be functional mitral regurgitation due to myocardial ischemia, dilated cardiomyopathy, infective endocarditis, hypertrophic cardiomyopathy, or trauma. Pathophysiology. Severe chronic mitral regurgitation is associated with left ventricular hypertrophy, left ventricle dilatation, and increased left ventricle and diastolic pressure, and subsequently heart failure. Symptom onset is related to the degree of left atrial compliance and underlying cause of the mitral regurgitation. Signs and symptoms of mitral regurgitation may remain asymptomatic for many years. The typical initiation of presentation will be exercise intolerance in the form of exertional dyspnea. This followed by symptoms of pulmonary congestion and congestive heart failure. The onset of symptoms may coincide with a period of increased hemodynamic burden, like pregnancy, infection, or others. Physical exam. First, there might be displacement of the apex bead on the chest wall due to left ventricular dilatation. Second is left parasternal heave or pulsation. Soft first half sound and blowing murmur, which is maximum heard at the apex. Tests and evaluations. First, ECG. It might reveal left ventricular dilatation or hypertrophy. Chest X-ray might reveal enlarged cardiac shadow, especially left atrium, in late cases. Echocardiography gives an important note about the valve state. Another option of echocardiography is transesophageal, which gives an important information about the state of the valve and the dimensions. Cardiac catheterization might be necessary for elderly patient management. First, it is important to consider giving anti-failure, digoxin, thrombolytics. Second option is surgical management by doing repair of the valve or putting a ring around the valve, apparatus sparing replacement, or replacement totally. Indications of surgery: when it is symptomatic or there might be structural damages to the valve, other surgical procedures needed like coronary artery graft. Recommendations of coronary angiography in mitral regurgitation. First, in patients with angina or history of myocardial infarction. In patients with one or more risk factors for coronary artery disease, where ischemia is suspected to be the cause of the mitral regurgitation. Mitral stenosis. Mitral stenosis is caused by structural abnormalities in the mitral valve that prevent complete opening during diastole. Etiology of mitral stenosis. The most commonest one is rheumatic heart disease. But other rare causes of mitral stenosis include degenerative, carcinoid syndrome, Whipple syndrome, obstruction by vegetation, and others. Management, again, consider giving anti-failure, digoxin, thrombolytics. Surgical options, balloon annuloplasty, repair conchoidotomy, apparatus sparing replacement, or replacement totally. Childbearing aged women need a special consideration, including even family planning. Timing of intervention. If the lady is not married, better to keep it conservative with closely followed up. If married with a satisfied number of children, it is better to do surgical intervention as soon as possible, of course, if it is indicated. Termination of pregnancy. In some of the valvular heart disease, it is necessary to terminate the pregnancy, especially aortic stenosis, as the increased hemodynamic demand during pregnancy might be burden on the valve disease. Regarding type of anesthesia, if cesarean section is indicated, best choice for the anesthesia is general anesthesia, with the availability of the cardiac supportive drugs, with the consideration of the use of heparin or warfarin according to the trimester of the pregnancies. Choices of the valve. So the choice of the valve type depends on the number of the children that the lady has. If she has more children and old enough, you can use prosthetic valve instead of tissue valve because the age of prosthetic valve is more prolonged. In general, choices of the valve. Age of the patient. If the patient is old, you can use tissue valve instead of prosthetic valve, as the durability of tissue valve is less in comparison to the prosthetic valve. Childbearing age discussed previously. If the patient away from the hospitals, better to use tissue valves instead of prosthetic valve, regardless of any other indications, because the patient might face difficulties in doing the INR test or the availability of warfarin tablets. Position of the valve. Durability of any valve in the mitral position is less in comparison to aortic position, as far as the leaflets closes against the very high pressure of systole, in reverse to aortic valve, which closes against the diastolic pressure. Uses of anticoagulants for other reasons. If the patient already on anticoagulation and complain of valvular heart disease indicated for surgery, better to change it for prosthetic valve instead of tissue valve, regardless of other indications. Patient request. In some cases, after explaining totally both types of the valves, it is the patient's right to choose between which one is suitable for his life. Availability of the valve. If tissue is not available, prosthetic valve can be used. If not, the reverse is true. Although it has been discussed to some extent, but generally there are two major types of valves, prosthetic valve and tissue valve, and the differences has been already mentioned. Some of the mechanical valve types, ball and socket, Starr-Edward, tilt and disc, Shiley, Medtronic, and types of tissue valve include porcine stentless, pericardial, Carpentier-Edward, homograft obtained from cadaver, xenograft from animals, autograft from the same patient.